Have we tried to go live again?
We have in progress for
Grinding away.
Oh, we're live.
we're live.
It shows that we're live. So I don't know if they can see the big Phil Petty or they can see us.
We just have to change the view.
Okay.
Yeah, I think we're good.
We're going, yeah, we are live. There you go, Charlie. Welcome, folks. We had a little technical issues this morning. This is House Corrections and Institutions Committee. It's Wednesday, April 12th. We're going to spend some time this morning with Department of Corrections talking about their health services and their new contract that they have entered into to deliver medical and mental health services to folks who are incarcerated as well. We're going to do some medically assisted treatment testimony after that. So we have with us Mac Titus, Director of Health Services for the Department of Corrections. As we well know, they just entered into a new contract, a different contract with a medical provider, WellPath. And the committee wanted to have some updates in terms of, I think in general too, Max, about the delivery of health services in DOC and how that's operating with a contractor, and then to talk a little bit more about the contract with WellPath. The new entity won't be coming in until July 1st. So give us a chance to have some understanding of the healthcare services. Welcome, Max.
Sure.
Just identify yourself for the record.
I'm Max Titus. I'm the Director of Health Services for the Department of Corrections. And I prepared like an overview since I know some folks might be new to our division and what we do. So I'll start with that and then I'll answer questions as they come up. So at DOC, we have a team of 8 positions that are responsible for our health services. So including myself as the Director of Health Services, we also have a medical director who's a physician. We have a director of nursing, a chief of mental health, director of mental health and addiction systems, who's Annie, who will be here after me later. We have a program technician who oversees like medical records requests, administrative functions. And we have a position that's a little in transition now, moving to a health equity director. So putting a health equity lens on everything that we do. And then we are pending hire for a position to oversee our electronic health record, which I can talk about more, but the contract transition that we're approaching also takes that model from a subcontract with our comprehensive health services vendor to a direct contract with DOC. So instead of our health services vendor overseeing the electronic health record, our team will be overseeing it directly.
Is that different?
That's different for this contract.
And what led to that being different? Is it more oversight?
Yeah, a couple
DOC
things.
wants?
DOC will have more control over the electronic health system and the workflows and how the data is received. And we are aligning the time frame with our vendor management system. So we've done a contract with this vendor for EHR services for 2 additional years while we go through an RFP process.
So that part of it is because we're going to be hopefully updating the OMS system. We want to make sure the medical electronic system and the OMS are compatible and can talk to each other.
Yeah. So that team of people, basically, we all work together. Our goal is to improve the health and well-being of justice-involved individuals. And we do that through health and wellness program development and oversight, intensive contract management, because most of the services we provide are through contracts, and continuous quality improvement initiatives. And we collaborate with AHS and other AHS departments on how we provide healthcare and aligning our care with the community. So our philosophy, if you're familiar with sort of correctional industries, there's this idea of correctional healthcare, and we do not believe in what's termed sort of correctional healthcare. We believe that healthcare occurs in our correctional facilities, but it should be aligned with our community as much as possible. And so we do strive for the community standard. And that is sort of how we've designed our contract and our health system, with a sort of holistic integrated health system. And I can talk more about the contract details of that. But basically our contract defines comprehensive health services as integrated holistic system of care, including medical, mental health, substance abuse, dental, vision, on-site and off-site specialty, pharmacy, care coordination, and emergency services. So that's basically everything up to hospital level of care is provided by our health vendor. So the contract that we have, and this is generally our contracts, this current one we're in and the new one in July, the contract requires compliance with the National Commission for Correctional Healthcare Standards, NCCHC, so they have to be accredited at all sites. It requires compliance with federal and state law, any DOC policy, directive, or APA rules. And like I said, the community standard of care, which is a little more difficult to sort of solidify, but we do use Medicaid as sort of a guideline for that. So two things that are really important to note about the contract and the contractor in this model is that the contractor has medical autonomy. They're making medical decisions, they're providing medical care. The DOC and our staff do not do that. We're providing oversight, but we're not making medical decisions. Another thing that's important is individuals that are in our facilities have to consent for care, just like anyone in the community, and they can refuse care and we can't force them to accept that. So I'll pause there, and then I also am prepared to sort of talk through what does it actually look like when someone comes in during incarceration and then as they approach discharge from our facilities. Any questions? Yeah.
They do, Chris, Chip, Chris.
So I'm curious by the term medical autonomy. So if the Department of Corrections gets sued for, let's say, lack of treatment rather than mistreatment, which we hope won't happen, but lack of treatment, how does that work? Who defends against any suit that may come as a result of lack of treatment, complaint of lack of treatment?
Yeah, that's a good question. In our standard state contract attachments, there's language about indemnification.
Okay.
And so they do have medical autonomy. Oftentimes where both entities are named in lawsuits, and then there's some determination of fault or of responsibility there, and then that's handled like in a legal.
Okay, that makes sense. Yeah, thank you.
The vendor that you chose has pretty big track record nationwide on various lawsuits and regulatory issues. Were you happy with the choices of vendors that you had?
So I know that we've sort of talked publicly. Technically, our contract's not signed, so I have some details I can't share yet. But we had two responses to our RFP, and we picked the better of the two.
Max, is there any consideration of maybe going back to having state employees provide these services? It seems like we shift contracts quite a bit. I would imagine the consistency of, care and maybe not having to retrain people every time would have some benefits.
So a couple things about that. So shifting contracts. So we have a limited term, so we can't do an indefinite contract with state rules. Usually our term is initial 3 years and then an optional 2 year, two optional 1 year extensions. So a total of 5 years, which is why it seems like we're shifting. We have to go out to an RFP process to get a new contract after that 5 years. That said, the process to do that takes about 1.5 years from RFP development to contract beginning. So it does seem like a good portion of our time is spent doing that process. There's always talk about it. Every time we go through this process, it's an internal conversation that's oftentimes raised to DOC leadership and agency leadership. And I can say from the most recent conversation prior to this RFP process, and what is probably consistently the challenge is two factors: is cost. Even though we tend to have a for-profit entity that's doing this with their profit factored in. They can still do this cheaper than the state could do it, which is also related to the second factor, which is human resource. A lot of these companies are large multinational or global corporations that are doing this work, and they have resources available to bring in staffing, to negotiate lower rates for subcontracted services like pharmacy and other vendors. And so even with doing it in-house, there's a cost barrier to do that. And then whether the state would even be able to acquire the staff to fill the facilities and provide the care is another question.
Thank you.
But we talked about it internally.
Yeah, could you just say a little bit more about sort of the routine way that healthcare is dealt with? So for example, if somebody gets sick, do they go in and have a physical appointment with a physician's assistant, or do they have a consult by video with somebody who isn't in the room? Like what are the usual processes that somebody who was encountering a problem, a pain in their abdomen or something, like how would you decide who gets a live visit and who might have a video consult?
Okay. Yeah, and I'll go into this in more detail when I talk about what it looks like, but just to answer that specific question. So there's a healthcare request form, which is usually called a 6-slip. And then there's also clinic times and walk-in times at certain facilities. So those slips are picked up sort of continuously, at least on a certain interval, and then they're triaged by nursing staff within 24 hours. And then that determines whether they're seen immediately by a provider or if they're put on a list to see a provider, depending on the consent.
But you usually have people available to meet whatever level of need would come up
Yep.
within the facility.
So there's nursing on site 24/7 all the time. And then there's on-call coverage if there's not a provider on site 24/7 as well.
Thank you.
Where is that 6-slip submitted to? Is it to a correctional officer in that unit, or does it go? to
Yeah,
the-
usually they're, it's a little bit, I think it's a little bit different location wise, but they're like boxes that they submit them into
In their
either
living
in the
unit.
units, and so they're picked up on a certain interval.
So the respondent, is it picked up and triaged within 24 hours? Is there a sort of typical or average time within which one can expect a?
I would say it depends on like when it was picked up, when it was submitted. The 24 hours is an NCCHC standard, and so that's part of the accreditation piece. There's timelines with that, and then obviously if there's emergent situations, those don't go through that process. That would be an immediate call to medical or whatever the need is.
Annie just joined us.
So
Hi, Annie. So what was the contract cost for Vital Core, and what is the contract cost for WellPath? If you've already negotiated that or not?
So yes, the cost has been negotiated and set. I can say, and this is not an exact number, but estimate the cost for VitaCore budgeted cost, and I have some asterisks about this, was around 21 million a year. That said, my asterisk is that was negotiated prior to COVID. It was negotiated and the contract was settled. I was just looking back at this. I think it was like the first week of March in 2020, just when everything was shutting down. We were settling our contract and routing it because they were transitioning in July. And so obviously the actual cost may be significantly different since the impact of COVID and then healthcare in general, staffing for nurses, supplementing with agency staffing.
And what's the contract for WellPath, the cost?
So that might be a piece that we don't release until
Okay, so-
the contract signed, but
I get it.
Yeah.
So we're in the $20+ million ballpark.
Yeah, yeah.
20 to 25 million, I would say, ballpark.
and I will say, I can say that there was a significant increase because of primarily driven by staffing at this point.
Are they having a hard time? Did Vital Core, and you can't talk about WellPath at this point, did Vital Core have a tough time with staffing? And I saw a lot of ads out in the paper.
Yeah, same as any health entity has had the same challenges. And, like you'll see it in a lot of nursing facilities or facility-based care, like a lot of staffing is contract or temporary staffing, because the ability to hire full-time nurses is limited.
So are they using traveling nurses? Are
Yeah.
they-
And that's always been a thing that we have included in our contract, and we don't set a very specific limit because we know there are factors outside of the contractor's control. But that's something that we've had to adjust over COVID because of the realities of the health system.
And are there different situation, maybe situation isn't the word to use, but is there a difference between our smaller facilities, I'm thinking like St. Johnsbury and Rutland, versus like the Newports and St. Albans and Springfield? Is there, I want to say operating differently and different needs, different requests, different length of illnesses? Is there, or is it the same regardless of which facility?
So there are some differences in the sense that at some of those, at Southern State, for example, we have the resources and the units and space for more acutely ill patients, whereas we don't have that at some of the smaller facilities. So oftentimes if someone needs a one-level facility, or if somebody needs to be in a mental health unit or in that type of situation, those folks are being housed at a facility that has that capacity. So there are differences in the needs. Sites that have infirmaries have 24/7 RN coverage. There's some different needs based on what they have the capacity for.
And when you switch contractors, the staff pretty much stays with the new contractor?
So the goal is that all of our incumbent staff remain. Obviously, it's not usually 100%. People choose to move on or sometimes aren't, satisfied with the new vendor coming on. But for the most part, the staff that are providing care are staying on. And in fact, we have a number of folks who have been providing this care through multiple contractors over, decades. And so, the goal is to retain as many staff as possible.
And their salary would stay the same, or does it change depending on the contract?
So we include some terms in our contract that the new vendor cannot uniformly reduce salaries. There's some allowance for one-offs or outliers in that, but that the salaries have to remain where they're at, or be increased if that's up to the vendor. And then the benefits have to maintain sort of a market standard benefit package as well.
So the provider, the medical provider, is autonomous in making the medical decisions.
That's right.
And what if, in your role, or even Annie's role, or DOC in general, what if there's some concern on your ends that, wait a minute, some of this is a little dicey, we don't really support this, maybe it's too much, maybe it's not enough? What happens then?
So that's a good question. I can talk a little bit about how we monitor the contract and the services, and that might be helpful. So we have some of the folks that I talked about earlier. A big portion of their job is reviewing patient level care, the folks that are acute, the folks that are decompensating, that are requiring additional attention. They're doing that on daily and a weekly basis. When doing that, they're gaining information about what sort of issues are popping up, what kind of medical decisions are happening. If we have concern about that, we have sort of a CQI, or continuous quality improvement process, that we can engage with the vendor, where we can reach out to them with the concern that we have a discussion, get a response from them. If we're still not feeling like our concerns are resolved around that, we can engage like a corrective action plan or a process where we work with them to resolve that issue. And, you know, whatever the issue was, we would bring in our subject matter expert that would be able to speak sort of peer to peer with the vendor's person as well.
Wayne?
So, of the people providing the services versus whoever they are they moving between facilities or are they autonomous to just one facility?
That's a good question. So some sites, you know, might share like a provider. And so you might have a provider that goes to multiple sites, or they may fill in at other sites, but they're usually designated to one or maybe two sites. You know, we have a staffing matrix when we're talking about staff, just to give you an idea. You know, we're talking about a ballpark of 175 full-time staff members. And so, you know, there's staff at the sites all the time. And then, there would be someone on site and then maybe, you know, would have to cover what usually they're at that location.
Michelle, my comment?
So I have a question about mental health care. I know with most types of healthcare, if you get to a crisis kind of situation where you need hospital level care, an individual can be transferred somewhere else. So I'm wondering if you could speak a little bit to when somebody goes into mental health crisis and they're in a correctional facility, where do you send them? And what kind of criteria determine that? Because like I know in general in the population, if you're a danger to yourself and other in terms of exhibiting self-harm behavior, that would be criteria for going inpatient in a psychiatric facility. But I'm aware that doesn't always happen in a correctional facility. So I'm wondering if you could just speak a little bit to that. Like, how do you determine when someone needs a level of mental health care that is more than what can be provided in the facility, and where do they go?
Yeah, so I'll defer the details to Annie, but I'll say there is a process for that. And it would be a similar process to, you know, someone was suspected to need that level of care in the community. There's an evaluation process, and then based on the outcome, we would determine where they would end up. So they may oftentimes not go somewhere else, but most of the, you know, we determine where they end up in our facility. So I don't know. You want to wait and pose that question for Annie later?
I think too, we have to be aware that we did a lot of work on this probably 6 years ago, 7 years ago, Annie, where
Yes.
and we tried to get this last session and we were not successful, but there is supposedly an MOU between DOC and Department of Mental Health in terms of delivery of services for folks with mental health issues. And we tried to get that MOU last year, and Department of Mental Health was like, they couldn't find it. So I would ask again, it would be really nice if we could have a copy of that MOU, if we could find that. Because
So-
DMH seemed to know what I was asking for last year.
So Annie Ramnasiano, Director of Addiction and Mental Health for the Department of Corrections, for the record. And you are completely correct, Chair Emmons. We did that work almost 8 years ago. It was 7.5. And we do have a very active MOU that has many different attachments. We absolutely follow to the letter of the law the exact same process that would be used in the community for people who are within our carceral setting. So the criteria specifically are Centers for Medicaid and Medicare criteria. It's the same evaluation process if you went into mental health crisis in the community. It's the same psychiatrists, the same everybody doing the evaluations. And if they meet the criteria, then we work with DMH and their care managers. They have a constant 24/7 updated bed board for the psychiatric crisis beds in the state. And we would work with them then to place the person as quickly as possible once they've been found to be a person in need of treatment, which is the essence of that law. So this is all in statute, and it happens on a daily basis. It's just simply become part of the fabric of what we do. I think it was a very important piece of legislation. It happened, with Chair Emmons' leadership. My leadership, the department before that time, was not putting people who were in mental health crisis in inpatient psychiatric care. So again, this is a real tribute to the efforts of this work group.
And it's also the delivery of services for folks
Yes.
who don't meet that level of acuity to go to one of our psychiatric beds to be stabilized. It's working with DOC and DMH to provide the best services within an incarcerated environment.
And the other thing I'll remind you that you did, Chair Emmons, is that then we worked very hard to augment the mental health crisis units that we do have within the facilities, because the distressing part of this is when somebody is deemed not to be a person in need of treatment, even though their behaviors may be really egregious and seem very the opposite, really need a psychiatric bed in a hospital. If the psychiatrists disagree that it really is behavioral and they're not going to benefit from psychiatric care in a hospital level of setting is simply stabilization, basically through medication. At that level of care, it is not ongoing psychotherapy. People at that level of crisis really are only there for stabilization with medicines. So if the psychiatrist determined that medicine is not going to be palliative in addressing the behavior of the individual, then they would stay with us. So again, this committee showed great leadership in supporting the department with financial means to augment our mental health units inside of the facilities. And now, because of that help, we have 2 soft cells, one at Southern State and one at Chittenden, that we can also use in a continuum of care, a suite of services for people who need that level of low stimulation and a safe place to be. Where all of these efforts are to reduce people with mental health issues being placed in segregation.
Are those soft cells used very often?
The construction took a very, very long time, as you may remember as well. And at Southern, I think they were just finished maybe a month and a half ago, 2 months ago, and probably the same at Chittenden. So we did a national search through the National Institutes of Corrections, all the directors, to find out what other states were using soft cells and how they were using it, to get some guidelines, clinical guidelines and policies. There were only a few states who responded to me, and then we basically worked with our contractor and security to understand when placement might be indicated. And to my knowledge, we have not placed somebody in the soft cells at this time.
Anything else, Michelle?
No, I'll follow up later individually. Thanks.
The contract's written so that the provider's subject to like the Public Records Act, like if there's emails between employees with the contractor or different records that don't obviously violate HIPAA, that the public can make a records request for those.
Yeah, so any work that our team does in conjunction with the contractor is subject to public record. And we do extend, although they're a private entity, so when we got a request, there are times where if we don't own that record, we don't have access to it, we refer the requester directly to the contractor to request it. And typically they do, they may have to redact or say we can't provide this, but typically they provide the same response that we would.
Thanks.
Interesting.
So,
Whoops.
Yeah, no, thank you. I was curious, really glad to hear that you've got the new soft cells. I'd say I'm surprised that they seem to have not been utilized. I certainly feel like, a lot of days I could use a soft cell. I don't live in a prison 24/7, 365. So is it clearly available? Do you feel like there's a need that is ready to be met?
defer to Annie on that.
So, it really is based on somebody's clinical profile and whether or not placement in that kind of setting would be beneficial. So I can't speak to whether there have been any emergent issues or cases where the individual would have benefited. So I'm happy with the fact that it hasn't been used. And the reverse way of saying that is that I haven't seen in my auditing and review of cases a situation where I think it should have been done. And if that had been the case, either myself or the mental health chief, Colleen Nielsen, who I supervise, would have been posing this question to the contractor. So back to how Max spoke to our monitoring of the contract and the deliverables. They have medical autonomy, but it is still within our authority to say, have you examined every aspect of this case? And what is the clinical opinion on the use of the soft cell in this situation? What are the pros and cons? Has a multidisciplinary team examined this thoroughly? Can you give us the rationale as to why or why not it's being used? So that's the way we push on clinical decisions, to gather more information while continuing an open dialogue and also allowing medical autonomy to occur.
Thank you. Do you mind, that's a really helpful answer. I'm just curious to see those clinical guidelines or policies for the cells. Is that something you could share?
So to date, we have not drafted our own set. What I was mentioning before was that I had elicited across the nation other states, people in my role in every state. I had asked them for their policies and procedures and who had them. And I really came up with only 3 states responding to me, and they did not have a set of policies and procedures. It was more like I've talked about here, that it's a more naturalistic decision in a multidisciplinary team about the placement in the cell. There was not hard and fast clinical guidelines promulgated by anybody.
Got it. Thanks for clarifying.
You're welcome.
Wayne?
That was my question. My question was, what are the criteria for using that cell? And I can understand that there should be some flexibility, but I would think that it would be reasonable or logical that you'd have some set of criteria for guidance, at least for making sure that you're consistent in how you manage that.
It seems a little bit like it's more subjective, and I'm just wondering if there was a grievance filed where an inmate felt that they really needed that soft cell, what the recourse would be if you didn't have any policies or directives in place for it.
Yeah.
Just a thought.
Be a lot safer if you had criteria. That's how you go about justifying your actions and defending yourself if necessary.
No, I appreciate your kind input.
We get it, Annie.
Yes.
So I know we're limited on time, but I want to come back to the for-profit entity because we get that often. And there are a couple of things that, we oftentimes hear about, like the for-profit entity model and the problem with that. And so we obviously understand that, and we build into our contract language to try and prevent the contractor from being able to provide less care or cheaper care in lieu of having more profits at the end of the year. And so we have provisions in our financial section of the contract that give them essentially a flat rate that's determined during our negotiations. So we essentially say up front, like, we will give you this rate of profit throughout the contract term. But we also build in language that requires the contractor to return any savings. So if it actually costs them less to provide care than what was budgeted, the money comes back to the state. There's no incentive for them to provide less care in order to increase their profits. So a lot of folks don't know that, and we oftentimes hear the for-profit piece, and it's usually construed as a concern because of the effect it might have on care. So I want to point that out. We also have a reconciliation process with the budget annually to determine like what was the actual cost of providing service versus what was budgeted during negotiations. And then we have 2 other things sort of incentivizing the quality of the care, which one is pay for performance metrics. So it's an incentive-based performance metric that if you, as the contractor, meet certain thresholds and provide certain outcomes in care, you get an additional incentive payment related to the positive outcomes. So we have those metrics built into our contract. And then we also have liquidated damages and holdbacks, which are used at times where the contract expectations are not being met. And that's a withholding of funds from their monthly invoices and so on. So I think that's helpful for folks to know.
John?
Could you elaborate on the liquidated damages?
Sure. So we built in and we've sort of strengthened it in this contract even more, that if our team identifies deficiencies in the services that are provided, and then we pose those questions, like Annie said, to the contractor about concerns about care or certain services, and those issues aren't resolved, then we have the ability to withhold certain amount of their invoice as a result of them not following through on the continuous quality improvement process.
Tristan, Michelle, Chip?
Thank you. With regard to the provision to return money to the state if they spend less than they budgeted, is that enforceable from an accounting standpoint? And what I mean by that is, you take a national conglomerate, they can easily move overhead around their balance sheet to sort of increase their costs in one area to sort of reduce profits.
Yeah, I understand. I understand what you're saying. So there's a reconciliation process and we require them to provide monthly, quarterly, and annual data around their expenditures with the backup and support for that. So for instance, offsite services, it's pretty easy to determine what the cost of offsite services has been because it's all itemized by patients. Staffing cost, we're getting the staffing costs and we know what the staffing rates are, so we can reconcile that. So we sort of built in our ability to determine whether the information we're getting is accurate. That said, there is a process of if, for example, offsite services was much higher than we expected, but staffing cost was less, there is the ability to cross that. And so it's really the overall contract for the amounts that don't include the profit rate and the P4Ps that we're looking at as far as savings. And there's the reverse as well. There's the potential for overage. And we also go through the contract negotiations process to determine who's responsible for any additional funds.
Michelle?
Yeah, I was just wondering, I think you said your title was Director of Health Services, and pretty much everything we've talked about is medical care. And I'm wondering if that is exclusively what you work on, or is there a capacity within your role to also do things like encourage facilities to offer, say, yoga and exercise opportunities, or encourage the commissary to provide not entirely junk food, or education about nutrition and wellness and how those things are connected within the prisons. Because it seems like in my experience working with individuals who've come out of prison, they don't have a lot of awareness of those things. And when they talk about what they love and what they remember from, snacks, for example, it's all just really not healthy foods. So I'm wondering if you're able to sort of help with some education and opportunities in that realm where they're a little bit more preventative, or is it really just focusing on the medical care, the after side?
No, that's a good question. So, sort of historically, we've been viewed a little bit as really contract monitoring, but actually our division is more of what you're saying. The challenge with that is some of those things are embedded in different areas of DOC and not directly embedded in our division. So for example, the things you're talking about with like bringing in extra services like yoga and things like that, is held under volunteer service coordinators, which are local to each site. And then they report through a different sort of hierarchical structure. But we do communicate with them and work on the programs. I know Annie does a lot of work and can speak more to that too, and bringing in more wellness-oriented programs for folks. But that's something we have been talking about, and we do have sort of that communication across other areas in DOC. Commissary and food services, like we do overlap as well with that. Barriers with that become similar to, we do that through a service. We're not doing it directly. And so you're essentially getting a package through a contract. So that's something we've looked at before. And it comes with some challenges to make changes to logistically. But yeah, I think that's the intent, is it's really health. That's why I said health and wellness is really how we're viewing it. And we're really like continually working towards that, having more conversations.
Thank you.
Jim?
So that's sort of the way where I was going. When you talk about incentives for healthy outcomes in the realm of healthcare, that would mean that the emphasis is put on preventive care rather than treatment of disease. And so kind of following what Michelle was talking about is that you don't have a lot of control over diet in the correctional centers. So that's one thing that would, as Representative pointed out, is that would be a lead to better health and wellness, and a number, again, diet and exercise and such. So I guess how's that worked out, I guess, is the question. Have your contractors actually succeeded in having incentives for well care, or has that just kind of been in the contract and not really happened?
So we do monitor all those metrics monthly, and if they are meeting those thresholds, then they're earning the incentive. I wouldn't say that they earn most of it, because some of them, like you said, you don't necessarily have control over some of the outcomes based on individual choices, but it is something that we've been increasing focus on. And with this contract, we also are planning to transition to a smaller set of metrics that are tied to the incentive, and then have some that are just our expectation. And so that's something we have conversations about. On this topic of sort of wellness, our division also has been collaborating with VDH on a data brief, which compares our population with sort of the social determinants of health, and including like the types of foods that folks are eating, exercise habits, things like that, so that we can compare that to the community. And I think it's done by county in Vermont, but we've been working on that. So it is a focus of ours, and it's something that we're constantly increasing our conversation and focus on.
Thank you. Can I follow? Annie, while we have you here, welcome back. So we've been having some discussion in the committee about MAT, and
She's gonna do that.
she's going to.
Yeah.
Okay, never mind.
Stay tuned.
Stay tuned.
But I just wanted to add to what Max said, Michelle, that is absolutely our focus. It's on whole health. And there's many, many things that I do on a daily basis that are building future infrastructure towards that vision, really helping to create more agency and self-efficacy inside of the culture of the community of each facility, and pairing that with wellness and health. If you all want a preview of what Max just talked about with our collaboration with VDH, you can go to the 3-4-50. If you just Google Vermont 3-4-50, it is the 3 health behaviors that cause 4 chronic diseases for 50% of the population. That's why it's called 3-4-50. And so that is what we're modeling, basically building off of this idea that the Department of Corrections population is like the 16th county in the state, hiding in plain sight, that these are individuals from every single part of the state, and that looking at their health behaviors and their health in general can also inform us as to the health and well-being and the access to care in the communities that they come from, right? We can trace this back to improve the healthcare in the community. And to me, that is the real systemic prevention at the macro level.
So we have a few more questions here, and then I'd like to move on to go through the process of when someone comes in through booking.
Sure.
And what happens at that point with
Sure.
the healthcare and mental health services. Tristan, then Wayne.
Sleep as a determinant of health, is that high on your list? And do you control the facility? Is that something you looked at?
Yeah, that's a good question. I think we have conversations and include those sorts of things, but there's some limited control, like from our division specifically around facility schedules, individual choices. I'm curious, Annie, have you had other conversations around this?
Yes, I mean, I think, Tristan, that the issue is complicated because the infrastructure is very anti-sleep. Prisons are hard scapes. They are cement. The sound reverberates endlessly. The clanking and closing of doors, movement of people, everything is very, very noisy. We do provide people with headsets. Melatonin is also available, and as are various over-the-counter sleep aids. There is also a Calm app and a meditation sleep app, several of them actually, that are on their tablets. We try to provide as many supports to sleep hygiene as we possibly can. Treatment of sleep apnea is obviously part of that too. People are allowed to have sleep apnea machines, special pillows to help prop up their necks and thoracic area to help with breathing. Again, it all depends on medical necessity. And then there are other things that are over the counter and that are available simply because we know sleep is really elusive for many of us in the community as well. We try to make it commensurate.
Are eye masks available?
I didn't hear you.
Eye masks available?
Yes.
Yeah.
Eye mask, yeah.
The other thing I would say about that is melatonin just doesn't work for some people, and they, some people can feel very frustrated that it's the most commonly suggested thing, and it doesn't work with their chemistry. But there are other very safe over-the-counter options that also support that kind of thing that can work with different people's chemistry. Do you offer options?
Yes, there are other options offered. The Benadryls, the hydroxyzines, things like that typically make people drowsy, would be offered.
Warm milk.
Alice, we'd like you to go and have a station at Southern State in their coffee shop. You could be offering warm milk.
Warm milk. There you
Yes.
go. There you go. Wayne and then
I was
Gina.
just amused since our representative over here is having a snack. I just think if we make the menu healthy enough, I can say that tofu and celery and a few of those other things would really probably keep us from recidivism.
Diet Coke keeps you.
Yeah, right. Oh, here we go. I'm not going down that road.
I'm just wondering, when did the incarcerated individuals get issued their tablets? Did the detainees have access to all this stuff? Or is it something that's just for people with longer term stays?
No, so I'll just say, I think anyone has access. It doesn't.
So once they get through the booking process, they
at
have
some
it.
stage in the process, but it's not dependent on your legal status.
Okay.
But it's also limited in what they can access through the tablets.
Yeah. It's not like you all.
us.
Right.
have
No, I
access.
understand that. I was just wondering for the sleep apps and everything like that, if they had that right away.
So let's transition to when someone comes in, they go through booking. What is, there's some requirements that are done, mental health screening, healthcare screening. Can you just go through the process there?
Yeah. So when folks come in, they go into booking. There's a booking process. So from the health side, there's an initial healthcare receiving screening, and that happens within 4 hours.
Is it voluntary in terms of how it's up to the person to fill it out as they?
No, it's an interview. So the medical staff is in booking and does this interview with the person. And that's where the screenings happen. I mean, obviously they have to answer the questions or not. And they have to be able to do that within that time frame for it to happen. If they're not, if they're intoxicated or otherwise unable to do the the screening at that time, they repeat the effort for the screening on a certain interval. So during that screening process, they're doing all of the initial screening. So they're asking questions about chronic illness, treatment or care they've been receiving in the community. If they're on any medications, that's when the medication verification process will start, which is another work of this committee with Act 153. And so if someone comes in on medications, there's a verification process. Those medications are continued. They're also asking, they're doing mental health screening at that point, screening for substance use issues. They're doing an initial dental screening at that time. And they're initiating any ROIs, their request for information, release for information for the community. And so all that's happening in that first screening, which is within 4 hours. From there, depending on the outcome of some of those things, there will be the disposition will be either an urgent or emergent sort of referral to a provider or potentially a mental health provider for additional assessment and evaluation, or maybe a routine, if not much is happening in that screening, it might be a routine referral, and then folks would have an initial health assessment within 7 days, and then the additional screening or evaluation for mental health or substance use as determined at that screening. So that's sort of the process. Everyone coming in gets that, regardless of incarceration status, and then they move through that process. And then the health assessment is a more in-depth, provider assessment of the person, and from there you're kind of moving into ongoing care. Someone has stayed through the 7 days to get to that point. The ongoing care is identifying any chronic illnesses or ongoing needs, and then they're assigned a chronic illness clinic, I think it's called in our EHR, which is a way of identifying someone needs to be followed regularly for a certain problem. And then they're typically seen every 90 days for whatever that issue is, or more frequently determined by the provider. So that ongoing care happens if there's a need for specialty care while they're incarcerated, something that's not provided directly by our contracted staff. They would be referred to a community provider, sent out to a cardiologist or a pulmonologist or whatever the need is. So they're essentially getting our Vermont community care directly in the community. So that's the ongoing. Obviously, if they qualify for the MAT program, and he's going to talk more about that, so I'm not going to spend a lot of time. Or mental health services, she can talk about also. So then sort of as you have like transitioning towards discharge planning or sort of the process of release gets a bit more complicated because of incarceration status, because of there are some folks who we can predict a discharge date and we know they'll be released within a certain time frame. For those folks, the expectation is connection to a community provider or appointments for follow-up in the community, medications or prescriptions called into a community pharmacy. So the person has medications at no cost to them until they get to their community provider. And then they're handed a continuity of care document, which is a summary of their care, the places they need to go, the contacts they should make to continue their care once they're in the community. And they're also provided like education and resources at that point. The trick is there's a significant population that we don't have advance warning about release. So we call those folks like rapid releases. They may be released from court on short notice. They may, meet bail. They may have some, condition of release met, and they leave us and we don't have warning. It's a bit trickier for that. So we try to start some of that release planning up front. So we're verifying like insurance at intake, so that hopefully like when they're released, if it's a rapid release, that will continue or we'll at least have that information. And we're just trying to like think about that up front from the time the person comes in. There's a lot of turnover and churn. So there are a lot of folks who come in and are with us for a very short period of time. Really, there's no like significant change to them as far as community providers. And then, so the trickiest population is not the quick turnovers, not the planned releases, but the folks who could be with us for a number of weeks or months, but we also can't predict when they'll leave. So I'm happy to answer questions about that too.
So what do you see when folks coming in? Are most of them hooked into a primary care provider or not? Do most of them have some form of insurance or not? What is seen for folks coming in?
So I could look more into the percentage that have a connection to community providers when they're coming in. I have to look into that. I think most folks do have some insurance connections, typically Medicaid is what we're seeing for most folks. So we're verifying that. And then that's also a piece of discharge planning, is verifying insurance is set up for folks as well. Trying to get all those pieces in place. Yeah, it's hard to say on the connection to the community. I have to look and see, we could look and see how many folks are being prescribed medications or signing ROIs at intake and get a sense of that.
Because when we've done work on this in the past, in terms of the continuity of medication of folks prescribe something in the community, we want to continue that. And testimony revolving around that, there are many, many layers to that, where a person coming in will say, oh yeah, I'm on this medication.
Yeah.
Check back with the pharmacy that they give you, and the pharmacist will say, well, it's been a couple of years, they haven't been on this medication, hasn't been refilled, but they don't have the provider. They'll give a name of their primary care provider. They haven't seen the provider in 3 or 4 years. So that was testimony that was given when we were doing this type of work. The other testimony also that's been given over the years is that a lot of folks that are coming in have not kept up with their health care or dental care. So DOC is really trying to make up for lost time.
Yeah.
On some of that. Is that still fairly accurate?
I would say generally yes. And I have some like very general ballpark statistics just to give you an idea of like quantity of services in the population. And I just looked at the most recent sort of monthly stats that we get to look at this. So we've been running around average daily population for the past several months, around 1,200, 1,250 in state. Of those at any given time, 1,000-ish are on a chronic illness clinic. Of those, 70% are on medications, and the average number of meds per person on a med is 5. So not just like a one medication or prescription. Around 50% are on psych meds, and around, and Annie could correct me, but 55 to 60% are on MAT. And so we do see that this population has high chronic illness, instances, and that's something that we deal with. We do, in January, we did around 300 receiving screenings in January. So it's about 300 a month is what we've been averaging. That's just the initial receiving screening. And then we're triaging anywhere from 3,000 to 4,000 sick calls or walk-in visits a month as well. So we're, I know there's a lot of, there's oftentimes conversation and wondering like, what are we doing? Like we're doing a lot of things. In this population and sort of trying to meet those needs.
So I have some questions, Tristan and Wayne.
A couple questions maybe, but first, just is there a sort of a snapshot of the numbers you just read off that we could, get a report on?
So we'll say we do have some information on our website that is public already, and I can send you that. It's going to be FY22, but we also get data from our contractor and could follow up with a sort of snapshot of that if it would be helpful.
I guess I'm interested in a little bit more granular data than I'm aware you have publicly. Like diagnosed, for example, like. You said, I've heard you say, the commissioner say that over 50% are diagnosed opiate use disorder. So that's an example of something I'm really interested in seeing alongside other major diagnoses. I don't know if
Yeah, there is, and Annie can talk about this, there's a lot more data on the MAT that's public and related to the evaluations that are happening, but I'll let Annie talk more about that. But if there are other, like more specific things, I can see what we already have, and it might not be publicly available, but we can share.
Can you go through that just again? You've got about 1,200 folks incarcerated, give or take. And about 1,000 of them need medical care.
About 1,000 are on like a chronic illness clinic, so they've been
Chronic
assigned to
illness.
some chronic illness clinic to be seen on a periodic basis.
And then is it about 70% of the 1,000 are on some kind of medication?
70% of the total population.
Of the 1,200?
Yes. And we get also this average daily population. It's because there's a churn. So we're in the past several months, the actual flows, the number of individuals has been more around 1,600 because of that churn. Like we have folks that are coming and going, but any given day, the average is about 12 to 1250.
Could you ballpark percentage of the typical population that has severe mental health diagnosis, such as a severe case of OUD?
That's a good question. Annie, do you know offhand how many folks have been on the caseload recently?
So it's actually a two-part question. Are you asking specifically for people with really serious mental illness? In our statutes, that's referred to as SFI. That is a population we track very carefully, and at any given time, there are no more than 50 people who have that designation. That designation is both clinically derived by our contracted healthcare staff if they meet the criteria as it is represented in law, and or they receive that designation because contiguous with their incarceration, they have been receiving a community-based waiver. We have a team of people and a system built across the Agency of Human Services to analyze the health databases to determine which waiver and whether it's contiguous with incarceration. Those reports come to one of our team members on a daily basis so that we can catch those people at intake or as proximal to intake as possible. If they have one of those waivers, the designation of SFI is automatic and it's permanent. But that designation also only exists within the Department of Corrections, again, as per statute. If you're asking about the greater population, which would be anybody on the mental health caseload, which is what Max just posed to me, that really is more commensurate with who the numbers Max already gave the committee in regard to who is on psychotropic medications. If you're on psychotropic medications, you're most likely on the mental health caseload. So then you're really looking at about 1,000 people who are being monitored in a slightly different way than somebody who's not on the mental health caseload. Those individuals would be most likely on a CIC, the chronic illness clinic caseload as well, because they, for certain classes of medications, they would have to be seen by a prescriber every 90 days. All of this is built into the infrastructure of how health and wellness and disease management is constructed, just like in the community.
How many folks are on the mental health caseload? Do you have that off the top of your head? Ed?
I don't know the exact number, but I could get back to you with that.
And opioid use disorder can be, my understanding is that clinically it can be classified as anywhere from mild to severe. Do you have any sense within that population where things fall?
Yes, I actually can pull it up for you right now. Currently, on our daily report from the contractor, we have total MAT patients of 564. The breakdown of that is that 447 are receiving buprenorphine, 111 are receiving methadone, and 6 are on naltrexone.
Thank you. Does that, and do you have maybe it doesn't track with what I'm asking, but sort of as a diagnosis, would all those just be considered severe if they're taking these things every day, or is that not how you would diagnose or classify people?
So I would say that everybody to receive medication-assisted treatment would indicate that they are moderate to severe opioid use disorder. And if you are receiving methadone, you are more severe because methadone is a much more highly potentiated drug. And for people who need methadone, it's an indication that they have a very, very long-standing chronic opioid use disorder. And those determinations specifically for the methadone patients are actually made by our community hub directors. The Department of Correction is not an opioid treatment provider, an OTP. We rely on the hub and spoke system externally to make those designations, and those patients are patients of the hub.
We can get into this when we get into the MAT, and maybe you could explain at that point, Annie, just before we get there, I would like to take a quick break for the committee too, but who is the hub and where is it located and what's the connection with the hub? So we'll get into that. Wayne?
You mentioned a waiver for what? What's
I think it was when Annie was talking about the designation for SFI. So if somebody is on in the community prior to coming into corrections is on a waiver for it's like a term for their services that they're getting in the community and how it's provided. So folks that are getting services at one of the DAs, one of the designated agencies, might be on CRT. And might have a waiver through Dale to provide services for their severe mental illness or other.
So if they didn't have a waiver, what happens?
So then it would be a clinical assessment.
What does the waiver get you? I mean, what's
waiving?
what are they waiving?
The waiver is just the term that's used for their payment mechanism in the community. So they get.
So they don't pay.
Well, no, a lot
So
of
it's how they're covered through Medicaid.
Medicaid.
So
Yeah.
It's a Medicaid bundled rate
Yeah.
that was determined with our 1115 waiver to the federal government, with the federal government. So it's a bundled rate that provides supportive and clinical services to the person according to whatever their disability is, whether it's mental health or intellectual disability, et cetera.
So it doesn't have anything to do with their mental state or anything else. It's purely a economic or money thing.
The term waiver, yes.
Okay.
But it is an indication that they have an existing set of conditions, and it was the intention of this body. I don't remember when the SFI statutes were created. I think it was maybe 15 years ago, Chair Emmons.
It was at least 15 years ago, and then it got updated because it's not a classification that's used in the community because it was impacting the CRTs. So then we redeveloped the definition of SFI. I think it was 6 years ago.
Yeah, maybe.
6, 7 years ago.
Yeah, because I know we worked on that.
Yeah, we've done it twice.
Yeah. So I think the intention of the body of the legislature was simply they wanted the Department of Corrections to have some mechanism to understand that somebody that has a potentially vulnerable condition was entering the facility, and how it really translates inside of our walls are amendments to the way we treat people, specifically in time and segregation, considering the impact of their disability on use of disciplinary segregation and things of that nature. So it's really like a canary in a coal mine of if somebody has the SFI designation, we know that they have some disability, they may need accommodations in how we respond to them. And it also allowed us to clinically be able to designate people, because some people have not received the waivers and the designation in the community because they don't go to healthcare. So they fell through the cracks, if you will. And then also some people decompensate in prison. So, it allowed us to protect them in that with this designation as well.
So What proportion of incarcerated people are on Medicaid? Or we're on Medicaid?
It's
Coming
very
in.
high. It's very high. Almost everyone Medicaid is their insurance.
Because we have expanded Medicaid here. From the Affordable Care Act, we took on an expanded Medicaid coverage here in the state. We did that.
That was expiring.
No, that's COVID. Really,
No, I
that's
thought there
expired.
was, I thought there were, that the expanded Medicaid was gonna expire soon.
What was expiring is dealt with COVID, that there wasn't the yearly reviews.
That was part of it.
That's part of COVID and to make sure people stay covered. But we have put in place when the Affordable Care Act passed back in mid 2000s, whenever that was, 2005, 2008, states had the opportunity to engage in expanded Medicaid, which meant that it increased the eligibility criteria for folks to be eligible for Medicaid. And Vermont decided to do that. So the bulk of folks who are coming into our correctional system have Medicaid or no insurance. Very, very, very few of them would have a private paid insurance. And once you become incarcerated, you lose all that.
Yeah. And that's a good point. When you're incarcerated, you cannot have your health care paid for by Medicaid. The only exception to that is inpatient hospital stay. So if someone is admitted to a hospital, for insurance purposes, it's covered by Medicaid, even if they come back to our facility.
And they can get back on once they're out.
And then once they're out, that's part of, for the folks that we know, release planning, and making sure their Medicaid is reestablished.
But there's an application process that takes time.
Yeah, the
So
process.
there's a lag there sometimes from the time they're coming out of the facility where they don't have any insurance. And that plays into not being able to access healthcare, not being able to access prescriptions, and not being able to access MAT. Because there is a time that you have to reapply through, I don't know if it's the exchange here or if you go directly to CMS for that.
So ideally, if we have advanced warning, that's all done prior to release. And so it's active once they're released. But there is like a step of the actual release has to happen, and then there's a verification that that's happened. For folks that are at rapid release, that it may take the time to reapply. There's challenges with the system in the sense that we can't pause Medicaid because of incarceration. So essentially it lapses completely,
Yeah,
depending
goes
on the
away.
time frame, and then it has to be reestablished.
Right, and
Some
I
of
just want to
that's-
emphasize that what Max is talking about is a federal law. It was the Social Security Act of 1965 that decided that incarcerated people's insurance, their Medicaid, was turned off. So it is not a state regulation, and there's not anything the Department of Corrections can do about that. What we have done to address that, and we just got the response. Max, do you want to speak to the 1115 waiver?
So in this, so DEVA, who is responsible for that waiver, worked with us many years ago to put in requests for basically an exemption so that our incarcerated folks could receive Medicaid paid services prior to release to assist with the release process, and to make that transition back into a community setting easier. So what we've just heard is that the California and other states have also done similar things, and they've responded to approved California's request, which was not identical to our request, and said to other states that they will only approve what they've approved for California at this time. And so they're saying it will be a couple of years before we get a response on anything additional. That said, there's some work to do on the DEVA side to make the systems from an IT perspective and the logistics to make it possible to do that. So we have initiated that process to be working towards the potential of having Medicaid cover services prior to release.
Even though they're incarcerated?
Yes.
So is this the same waiver? Because we had a facility that had a waiver, right? I thought we had a facility that had,
That's our mental health. That's our state hospital
That's
and
state
our
house.
retreat. That's different.
but that's not the same waiver.
No,
No,
no, that is totally different. We're gonna hear about that at 11 o'clock when we talk about forensic. We're gonna hear about that. Tristan and then John, did you have your hand up or not? No?
Yeah, I did.
You did, Tristan and then John.
So you have a minority, but some folks that are not on psychiatric or chronic medication. Just probably this just has to be anecdotally your impression, but how many of those individuals would you say are well? Is this a healthy human being, or how many are refusing care, or they're getting their medication through some other route?
yeah, that's an interesting question. I guess I would say that it would be sort of hard to say, right? Especially for me, I'm not working in the facilities directly. I'm seeing more of the whole population from a data perspective. I think we have a lot of folks who do refuse care, and we're very clear that that is their right to do. When that happens, we present them with a form or documentation that that's the case. There's checkpoints for folks that aren't in those sort of CIC lines. So it's not just like intake and then we never talk to you again if you seem well. They're similar to a primary care provider in the community. A determination will be made of like how often you would have an annual or biannual type exam. And so that's happening. But it would sort of be hard to say, like, are they really well? They're incarcerated. So.
Yeah, since they have to fill out that form, do you have any numbers on that?
We do have we can do numbers on, I don't know them off the top of my head, but it would have to be sort of specific, like what are we asking for refusals about, right? Like, is it the assessment process, or is it, chronic care follow-ups, or?
On an annual basis, how many of those forms do you process?
Yeah, we could do that. I don't have it offhand, but.
Thank you.
John?
I haven't heard much about the folks down in Tallahatchie, or could you give us a little rundown on the care level they're getting and how PLC monitors it?
Sure. So it's very separate from what we talk about with our in-state folks. So we have an out-of-state unit who manages that contract, and the healthcare is part of that out-of-state contract. So our team does not monitor that care in the same way that we are looking very closely at our in-state folks, because through that process, that contract with the out-of-state vendor, those individuals are Vermonters, and they sort of become that facility and they follow the facility procedures there. We have conversations with our out-of-state unit, so about the contract and what should be included and whether we should include, NCCHC accreditation, what the services look like to compare to our services. Annie's been really involved in conversations about MAT programs and whether we're able to send our folks on MAT out of state. So it is a very separate, we don't have the same day-to-day eye on the patients that are in the out-of-state facility. And they have their own sort of procedures for care that follow the contract.
Good.
So we've gone pretty much in depth, and I know we've transitioned a little bit here and there to the MATs. So what I'd like to do is take a quick 5-minute break, but I want to make sure that people have had a chance to ask questions that they've want. And if Max, you have anything else to say before we take our break, and then come back and start off with Annie with the MAT. So anything else, Max?
Just thinking of our upcoming contract transition. So we're anticipating our signing fairly soon of the contract, and then we're really full into a transition process, which we've already started some of those activities. So even though we say July 1, we're really working with this vendor. We've already started that process. And so, that's a 60 to 90-day process on this end. And then it goes into, once they take over, assessing the current state and making changes to come up to the current contract standards.
Anything else? Thank you, Max. Thank you, Annie. Annie, we're gonna take a 5-minute break and then we'll come back. We'll start with you. And if Max wants to stay in the room, you're more than welcome.